All right. How you doing, Kelly?
Good. How you doing?
I'm doing pretty good. I'm doing pretty good.
Good.
Whew. It's hard to get these in, you know?
Yes.
Yeah. Doing pretty good though.
You have a piece of glitter.
Oh, it's from my other job. All right. Well, what are we talking about today?
So what we wanted to cover today was who is eligible or who is a good candidate for hormone replacement therapy.
Who indeed? Mm-hmm.
Well, first off, we should just say, hey, welcome back to the
Welcome back, everybody.
Kyndl podcast.
We're the Kyndl Health Podcast. My name is Dr. Tanner Tollett. This is Dr. Kelly Berger. We are a married couple, married doctors that are venturing out into this hormone optimization for who is what we're going to answer today.
Exactly.
So who is this for?
Yeah.
Yeah. Well, so first of all, I guess we could talk about what do we think that people think about HRT? What are some common stereotypes that might have existed, I don't know, 10, 20 years ago about people that take testosterone and hormones?
That's a good starting place. So there was a landmark study, the Women's Health Initiative, that was back in the early 2000s that really was a big deal in when it got published, because there was some suggestion that hormone replacement therapy in females was dangerous and shouldn't be continued long term. And some of the nuances of that was that the types of hormones that were used in those females were not bioidentical. It was equine estrogen. It wasn't bioidentical.
Equine means horses.
Good. Yes.
Yeah.
Yes.
From
Actually,
horses.
yes. Estrogen that they derived from horse pee, actually. And so for a good 20 years after that, really, in standard medicine, providers and patients just got really scared about the potential risks of things like blood clots and worsening risk of cardiovascular disease, development of breast cancer, and it really slowed the progression of hormone replacement, especially for females.
Yeah.
So I would say that testosterone replacement in males has been around for decades, and has been more widely accepted. There was a recent trial published called the Traverse trial on the male testosterone side of things that also was beneficial in disproving many things for males and testosterone replacement. So those were the two main trials that I would say kind of affected kind of where we are today, like landing today, where I think that hormone replacement is becoming more widely accepted, and providers are learning more about it, and we're seeing kind of a new wave in patients seeking it out. So I think that overall people are changing their previous thoughts on hormone replacement.
It's interesting how you answered that question. I think you answered it more of what were the stereotypes from providers.
Okay.
I meant what would a person think, typically generalizing, what has been the stereotype of people that use hormones over the last 20, 30 years.
Oh, okay.
I will. What comes to my mind is performance athletes, bodybuilder meathead types that are just, trying to bulk as much as possible, get as thick and ripply with muscles as much as possible. These are stereotypes, by the way. I'm just covering stereotypes. Or people with like like total glandular failure, people that have, they've got a real problem because they're taking hormone, their body doesn't make hormones. So they have to, it's a real medical problem for them. I probably had that same perception as a younger man of people, even some patients that I maybe saw in residency of that were taking hormone replacement. That's what I would have thought. And particularly since like testosterone is a controlled substance, like, ooh, there's some, maybe stereotypes around that. I think it got probably a bad rap because people were using it in the pro athlete world to get an edge, and so it became a controlled substance for that reason. And it probably doesn't really need to be. You can't really abuse it, and so and if you do, people will, it's pretty apparent, I would think. You can become one of the meatheads, but you have to be like, that's not going to be our patients. So what we're trying to answer today is, who is this for? And I think reframing those stereotypes into, this is actually for more people than people realize, right?
Yes.
That it's not for just these fringe groups that I might have just mentioned. And so also, what does it, who qualifies? Like, who needs it? Is it that person that just doesn't make any hormones, or can you have a little bit of hormones but your symptoms? That's the part that I think you were probably more talking about at the beginning.
Yeah. Good point.
Sorry, that's just what I was. That's my question. Yeah,
that's good, because I didn't understand that was kind of where you were going with that question. Yeah. So
I want people watching this to understand and maybe be able to relate to perceptions about HRT and
right.
Who's this for? And I think that would have been my assumption, is that it's for, not just for the normal average Joe.
Right. But it can be. There is a lot of different indications, or, a lot of different populations. And, gosh, it's just such a kind of a big, I don't even know where to start, right?
So if I have a normal testosterone level on labs, I get a testosterone level from my doc, and it is within the normal range. Does that mean it's not for me?
Not necessarily.
Not necessarily.
Yeah, good question.
Tell me why.
Oh, that was a good question. Thanks for helping me out with that.
No problem.
So, first off, there's a big differentiation between normal lab values and optimal lab values. The quote unquote normal lab values, we use the word normal, that comes from reference ranges on lab results. And the way that those have been published is, they say, quote unquote, from the normal healthy adult population, right? But if you think about who is usually getting labs drawn, it's usually not the, age range of like 20 to 35, quote unquote, normal population, right? As you get older, right? With aging comes more disease and or just more involvement with doctors in general, which leads to more lab values. And so anyways, these reference ranges, quote unquote, are from a normal, healthy adult population. But, one of the thoughts is, well, how do we really know that they just basically took a bunch of lab results and found the average of it, and then, took the ends of it as the low and the high, and that's where they kind of came from. And so that's where we call normal. And then, then there's this whole realm of optimal, where lots of people go to the doctor and get their labs drawn, and they're saying, gosh, there's just something off. I just don't feel well. We'll get into all of the symptoms, but right, I'm fatigued. I've got brain fog. I'm not sleeping. I've got anxiety. I just don't have energy. I don't have any emotional drive to do things. And it's like, well, all your labs are normal. And that's where that
That's where that phrase comes from.
Exactly. That's where that phrase comes from. And so then, going into could they be better optimized?
Mhm.
And that would be the answer.
Or does that reference range not fit you?
Right.
And we've even run into this a couple times recently where someone just gets a total testosterone checked and there's other things that affect how much of that testosterone is available. And so, yeah, your number might have fallen in the normal range, but that's not a usable number.
Right.
You're not using it.
Right. A little bit more detailed information on other lab values, like a free testosterone, a sex hormone binding globulin, other things that could go along with the hormone panel that could lead us to better knowledge.
Yeah. Okay. I think another question we need to answer to better guide who is this for is who's it not for? And I think I can guess how you might answer this a little more sciencey than me. So I'm going to go first.
Okay.
I would say it's not for people who are chasing numbers. So people that I want a testosterone level of 1,000, and I want it to be that number. I think that is the wrong mindset. And so I would say, we take a resolution of symptoms approach rather than number chasers. I do think there is probably a certain percentage of people, a certain population that does overuse HRT when they maybe don't need to, because it's not indicated for everybody. I mean, if you really are making adequate hormones on your own, and your symptoms aren't necessarily fitting with that low testosterone or low progesterone profile, then taking hormones it's not gonna fit everybody. It's not gonna fix it. It's not gonna fix what you're saying. I would also say it is not for people who are unwilling to change anything else about their lifestyle. So
good point.
if you're not gonna try to work out and try to eat better and sleep the right amount and have good sleep hygiene, and you're not doing all of those basic things, the eat your fruit and vegetables stuff, then HRT is not gonna. It's not gonna be a cure-all. It's not gonna.
Right. It's not the magic bullet.
It's not the magic bullet. It's the icing on the cake. So you got to have the cake first before you put the icing on it. It'll get you that extra 20-25%, that something's just missing, and I'm doing all the right things, but I still feel tired. What else is there?
That's such a good point, because that's true, and almost looking at it from kind of like the opposite angle, also saying to best take advantage of the assistance of hormone replacement, like maximize the value that you're getting out of it by maximizing your lifestyle habits,
Right.
and increasing your activity. I love that. Creating good habits if you don't have the habits, just like you said, sleep hygiene, watching what you eat, decreasing your alcohol, doing all those things that could be contributing to you not feeling very well. You can't be going out just, drinking a bottle of wine a night. I mean, not sleeping, little exercise, sitting all the time, those are going to make you not feel very well.
Yeah. Yeah.
In general.
And those are the big things. Those are the things that self-care things that, but you're not going to be able to get your testosterone levels up just by cleaning up your lifestyle. And,
Right.
There is a point where, okay, you do need a little extra, but you have to be willing to put in the work also. Yeah. What are some of the sciencey reasons that somebody shouldn't be on replacement?
Yeah, so that's a good question also. And there certainly is a little bit of a gray zone, I would want to start out with, that always requires a informed discussion between a patient and the provider, talking about risks and benefits and alternative treatments, because alternative treatments to hormone therapy is not taking hormone therapy.
You won't die without it.
Right. So I just want to start out with that, right? Because everybody is different and every case is different. But the big, the big things that people would think about would be active prostate cancer or active breast cancer or hormone sensitive cancers, which get very technical,
Yeah.
And so I would say that if someone held me down and said, no, you got to say who shouldn't take it. Of course, there's nuances, and so it's not as black and white as that. But if I had to say something like that, that would be one population that it would require a lot more discussion, a lot more risk-benefit discussion,
if you have had cancer, or especially active cancer, then boy, that's a red flag. Maybe we consider something else. And not all cancers are that way. You can have had something simple in the past that's not hormone sensitive, and that's not a big deal.
But certainly, in the prostate cancer world, there is some data that's come out that, if you had a prostatectomy, you've got an undetectable PSA, and it's been undetectable for 6 to 12 months. There are certain populations where it still can be a consideration. Other populations that would come to mind, and again, it's a gray zone, kind of depends, right? It depends on the provider, it depends on the patient, it depends on the risk benefit discussion, would be clotting disorder. And that just takes a lot of discussion and a lot of navigation, because there's a lot of studies out there that have actually proven that hormone replacement does not come with an increased incidence of venous thromboembolism or
some
clot development.
Really well designed studies too.
Exactly.
But that doesn't delete the published studies in the past that were probably incorrect, but have disseminated nonetheless. And so if you were on HRT and had a clot, there's going to be a huge chunk of docs that are going to be like, well, it's because you're on hormones.
Right. And again, that kind of circles back around to those nuances on those previous studies where they were non-bioidentical hormones, back to the Traverse trial where it did show that there was no increased risk of developing venous thromboembolism. Testosterone was the Traverse trial. So again, nuanced, gray zones, lots of discussion around it. But I mean, those are the top two major, higher risk is not exactly the right word, but those populations that require a little bit more discussion.
Yeah. And there's some fringe weird ones like Indian 1 and 2 and, some rarer things that out there. But that's not even worth talking about, I think, right now, because that's not going to be the majority of people, I would think.
So diving into who is it for, again, like Tanner kind of noted, it always takes an initial kind of like discussion and a review, right? Well, what are your symptoms and what are your labs, right? But hormones have been declining for the last 20, 30 years. Testosterone has been, across the board. And so, why? That's a very nuanced question, and a lot of people have theories. One of my theories has to do with the endocrine disruptors and the phthalates and the xenoestrogens and all of just like the junk in our food, in our cleaning products, in our beauty products, everywhere. These things that are disrupting hormones, really hormone disruptors, that goes along with the increasing infertility issues across the world, or at least in the United States, And so there are a lot of people that would benefit from hormone replacement simply just because of all of the hormone disrupting things that we encounter on a day-to-day basis.
Yeah. And when you say hormone disrupting, I mean, essentially it's estrogen dominance, right? And like all these, phthalates, xenoestrogens, things that are in plastics that get into our food, get into us, increase estrogen levels.
Right.
And kind of my thoughts on it is that's why, onset of puberty for girls is getting earlier and earlier. For males, the decreased testosterone and the, I don't know, decreased whether it's culturally acceptable or not, decreased masculinization of males, particularly into their adult years, compared to, you know, somebody you'd picture in the 1940s, you know,
Right.
going off to World War II. It's a little bit different, I think, now.
So for females, I would categorize it into, you know, there's a population of premenopausal females, right? And that population is for sure a population that could benefit from hormone replacement in certain instances. Things like PMDD, or premenstrual dysphoric disorder, and migraine headaches around menstrual cycles, and PCOS, which tends to be a progesterone deficiency type of issue, are
And
all things.
If I can cut you off, I would point out that is currently the treatment for some of those, for migraines and for PCOS, is oral contraceptive pills, which we're not a big fan of because those do increase thrombosis and aren't bioidentical. But adding hormones to those conditions has been pretty well established already.
Good point. And so then taking it the step further of saying, because birth control or oral contraceptives are not bioidentical hormone replacement, that's where the differentiation lies in considering bioidentical progesterone rather than an oral contraceptive that, just like you mentioned, you know, the oral contraceptives come with the risk of increased risk of clot and things like that. So I would say that that's one of the populations, are like menopausal females, younger females, you know, in their 30s more so, that people wouldn't necessarily jump to think, oh, they need hormone replacement. But certainly those types of disorders, even sometimes just heavy menstrual flow, that can come along with PCOS or things like that. And so that would be the premenopausal. And then, of course, with aging into the mid 30s, early 40s, that's usually where we see females start to be done having children, which seems to, I don't know if it's the age or the being done having children, but that's certainly where females tend to see more of a hormone changes, and they start to notice that they are having trouble losing the midsection weight, you know, feeling a little inflamed, having more anxiety, not sleeping as well. And certainly that comes along with considering, oh, could this be something that's off with your hormones, right? And that's certainly a good group of ladies who would benefit from having their hormones checked. And then, of course, with an informed provider, looking at those labs, optimal versus normal. That's where that nuance comes in.
Yeah. Are there any age limits to any of this? I mean, if I'm 20 and have a testosterone of 100 and it's just in the tank for whatever reason, whether it's environmental or whatever, is there, do I have to be a male in my 40s or a female going through menopause to do replacement?
There's no hard, solid age group. Every patient is different. And of course, it takes a lab check to just kind of look into things, but not necessarily.
Yep. What would be, I mean, so common symptoms. I mean, we could talk about kind of what we experienced, but common symptoms that would prompt somebody to think, oh, maybe I'm one of these people. What would you say?
Well, I mean, I kind of went through a few of those with the females. I was getting into the 30s and 40s with the decreased sleep, the anxiety.
You say, just say them all again.
I mean,
no. Rewind if you want to hear it again.
Other symptoms that would suggest that that estrogen dominance type of picture would be kind of going along with the premenstrual dysphoric disorder, which is like when you get like really emotional or almost even like angry or have a depression or almost like manic.
She's saying this, not me.
Right before your period or during some part of your menstrual cycle.
All the guys out there are like, well, yeah, we know.
No, but if you have something really clinically PMDD, like you know it.
Yeah.
You know it.
Yeah.
But, slightly increased irregular cycles, estrogen dominance comes along with like increased breast tenderness around the time of your menstrual cycle, irregular cycles, they're getting heavier, they're getting lighter, things like that.
Yeah. Yeah.
So for men,
and for men, it's you just all of a sudden don't have that singular focus or drive to do anything that you used to like doing. You almost feel like it's almost just defeated. You just feel a little slower, brain fog, weight gain that's hard to get rid of, decreased muscle mass. I'm working out 3 times a week and just not seeing as much gains as I used to. And all the mental health stuff too, depression, anxiety. I think those are the biggest. Sleep disturbance can happen, so you can get either insomnia or just trouble getting a full night's sleep. I think that's pretty easy for guys to tell. Oh, and a decreased libido. That's the big one, right?
Right.
Decreased sex drive. I mean, if it doesn't take a doctor to say that an 18-year-old male definitely is more interested in sex than a 50 or 60-year-old male, and that's from that testosterone decrease. So inability to maintain erections, softer erections, maybe none at all, and of course just overall decreased sex drive, just decreased interest. Mm-hmm. Yeah, that's a big one. Mm-hmm. And that's a lot. That's one a lot of guys don't want to talk about either. They don't bring that up.
Right.
It's not an easy topic to talk to anybody else about, but it's pretty common. It's pretty common.
Yeah. And same with females, right?
Yeah.
Decreased libido.
Yeah.
Pain with intercourse.
Yeah.
Difficult to climax.
Yeah. Yeah. And so what would it look like for somebody that's this is resonating with? Yeah. What do first steps look like? Is it something that, I've got to go straight and start injecting myself with this thing that I'm unfamiliar with? Or what are the steps to lead up to that?
Well, I mean, getting your labs checked. Mm-hmm. That's the first step.
I would say a conversation even before that.
Oh, okay.
Having a conversation with a knowledgeable provider.
Yep. Good point. Thanks.
Because those nuances exist. You may not be a candidate. You know.
That's true.
You might have these symptoms and we say, ooh, sorry, you have this big contraindication that, we don't want to make worse. And so you're going to have to find some alternative way to do this. Mm-hmm. But I would say a conversation and talking about, most people, it's easy enough. Most people don't have those big contraindications, but.
So one big population though, that we haven't talked about, right? I feel like we've gotten up until like the 40s. Mm. And then a big point is that it's never too late to start. Yeah. In older females, we see increased urinary tract infections. In older females and males, we see decreased muscle mass. We see osteoporosis or decreased bone density. And hormone replacement therapy is one of the only things that actually has had studies that prove that it helps improve your bone density rather than just slowing down the decrease in your bone density. And so the older females especially, it's the bone density and the frequent urinary tract infections, which come along with decreased estrogen and a change in the vaginal tissue, which leads to increased infections. Yeah. Yeah. So it's never too old to start. Yeah. The earlier, the better. But, we talked about that Women's Health Initiative, that study, and there's a population of ladies who unfortunately missed out on starting in their earlier years of the premenopause or perimenopause. And so it's never too late to start.
Yeah. And as hospitalists, I would say we see this a lot. The 80-year-old that comes in because he or she fell at the kitchen sink and broke a hip.
Right.
Or the hip broke, and then that's why they fell, right? And so and as hospitalists, we know that is the sentinel event for a lot of stuff. I mean, that's a long recovery, fraught with complications. Depends on how mobile they are afterwards. You can lead to DVTs and PEs or bed sores
Blood
if they're
clots.
not or if they're not getting out of bed. It can lead to bed sores, infections. An unrepaired hip fracture carries a 90-day mortality of like 30% or something like that. So if you do not repair a hip fracture, then you're pretty much going to die of something at that age range. So what can you prevent? How could that be prevented? Well, increase bone density, increase muscle mass to improve balance. If you're 80 and have these little thin muscles that don't do anything, barely hold your body up, you fall.
Fragile bones.
You fall and you break stuff, and then you're stuck in a nursing home for 6 weeks at least until your hip is healed.
Yep.
So it'd be a simple way to avoid that, right?
Mm-hmm.
And so kind of back to first steps, easy enough conversation with us or a knowledgeable provider. I would say, things to look for. Obviously come to us, right? We're, accepting patients for sure. But when you're looking for a provider to, let's say somebody's out of Colorado watching this, like what would you look for in a HRT provider?
Certainly someone who prescribes bioidentical hormones.
Mm-hmm. Mm-hmm. Yeah. I would say if you get the impression that no matter what your answers are, you're going to get sold an HRT program or plan, and that HRT is for everybody, and regardless of what your levels are, here's more. I'd say that's a red flag to me. That sometimes the answer is like, well, we can do a little, or maybe you don't fit maybe you're not a candidate. And then somebody that's, I think, available and up to speed on the newer studies that do not show as big a risks that we've become accustomed to.
So I got a question for you.
Please.
Do you have to take it forever?
Good question. Yes and no. If you are hormone deficient, whether progesterone or testosterone for males, that is very unlikely to come back on its own.
Especially with aging.
Because
with aging, your production of hormones is going to continue to decline.
It's going to decline. And we already mentioned all the environmental factors that are working against us. So it would be wishful thinking to think that, if I just wait a little bit, this is going to turn back on for me, and I'm going to start making testosterone again or progesterone, or, that this is somehow going to kick back on. So in that regard, yes, your deficiency will kind of always persist the rest of your life. But does that mean you're stuck on it? No, you can stop. And if it's something, whether financial or some contraindication develops or some reason you have to stop, you can stop. Your symptoms that you're experiencing now will probably come back.
And those benefits, you'll have the benefit while you've been taking it, but then you're not going to maintain those daily benefits. Yeah. So one of the analogies, because I just like talking about this analogy a lot, is that, someone who has high blood pressure, right? We put them on a blood pressure medication, and we don't get like 3 months of good blood pressure readings and then say, it's fixed. Stop your medicines.
Yeah.
Right? Yeah. And that's because they have essential hypertension. They have high blood pressure. And of course, that's also nuanced. If you lose weight and this and that, sometimes people can come off their blood pressure medicine. But standard procedure is not to say, oh, great, we fixed your cholesterol with this cholesterol medicine, so now stop it. Or we fixed your blood pressure with this blood pressure medicine, so now stop it. It, is a maintenance thing. Hormone replacement is a maintenance medication that helps keep those labs in the optimal, keeps your hormones in those optimal ranges as you age and as your body is not going to be producing as much.
Yeah.
So it's a personal choice and a personal preference. But if you wanted to stop it, you could.
Yeah. and your body's not gonna all of a sudden, decay into dust if you
Right,
stop. It's not. But the benefit, like I said, icing on the cake, the benefits that you see when you're on it will disappear, and you'll have those symptoms again. But so if you're fine the way you are right now,
Yeah.
symptomatic, and that life is fine for you, then that's great. That's what you would go back to.
Yeah.
So no, you're not stuck with it forever, but your deficiency probably is going to be there forever.
Mhm.
Yeah. Cool.
So
Or,
some of the just, he's saying, yeah, do you take it forever? Yeah. When do you stop? When you die. If you're someone who wants to maximize your
Yeah.
hormones
Yeah.
throughout your aging life.
Yeah. I agree.
Yeah.
I plan on doing that.
Yeah.
So would encourage everybody listening to, self-reflect, self-analyze. If any of this sounds like you, think about it, read up on it, watch the rest of our podcasts.
Get some steps.
Get some steps. I do definitely still do all the fruits and vegetables, exercise,
Wear some sunscreen.
track your macros. You do all.
Sleep.
There's so much
All that
other stuff you got to do too, and we'll talk. We can talk about that on other podcasts for sure. But yeah, thanks for joining us, guys. And catch you next time.